infection of upper jaw. Introduction. Facial spaces are facial-lined tissue compartments filled with loose irregular connective tissue that can be inflamed when invaded by microorganisms. When the facial spaces are involved, then simple infection becomes complex odontogenic infection. General management for all facial spaces, medical support of the patient with special attention to protect the airway, and correcting the host defense compromise when needed. Surgical removal of source of infection, surgical drainage of infection, administration of correct antibiotic in appropriate dose, frequent reevaluation of a patient progress toward resolution. Maxillary facial spaces, buccal space, infraorbital space, infratemporal space, palatal abscess, cavernous sinus thrombosis. Buccal space occupy the portion of subcutaneous space between the facial skin and buccinator muscle. Boundaries. Boundaries superiorly zygomatic arch, inferior border of mandible, laterally skin subcutaneous tissue, medially buccinator muscle, buccopharyngeal fascia, posteriorly anterior edge of masseter muscle, anteriorly posterior border of zygomaticus major and depressor. Content: buccal pad of vas, tension, parotid duct, anterior and transverse facial artery and vein. Clinical feature: dome-shaped swelling on the anterior aspect of cheek, extended anterior-posteriorly from corner of the mouth to angle of mandible, and superior-inferiorly from level of zygomatic arch to inferior border of mandible. Spread of infection: infection from maxillary premolars, molars, and mandibular premolars. If the roots are localized above the buccinator muscle incision, infection spread into soft tissue of the cheek. Incision and drainage: the intraoral incision is made at posterior region of the mouth in anterior-posterior direction and carefully to avoid of the parotid duct. A hemostat is then used to explore the space thoroughly. An extraoral incision is made when intraoral access would not ensure adequate drainage or when the pus is deep inside the space. The incision is made approximately 2 cm below and parallel to the inferior border of mandible. Infraorbital space: it is a thin potential space between levator angulioris and levator labii superiors. Boundaries: superiorly levator superiors alkinazi and levator labii superiors, inferiorly caninus muscle, medially anterolateral surface of maxilla, posteriorly buccinator muscle, anteriorly orbicalis oris. Content: angular artery and vein, infraorbital nerve. Clinical feature: swelling of cheek, lower eyelid, upper lip, dropping of angle of mouth, nasolabial fold, obliterated oedema of lower eyelid. Incision and drainage: incision through mucosa of buccal vestibule of lateral incisor and canine. Drainage: a curved mosquito forceps is inserted superior to caninus muscle, pus is evacuated and drained is secured. Infratemporal space: rarely infected, but when its infected cause is usually third molar. Care should be taken while giving buccal infiltration anesthesia to third molar to avoid injury to pterygoid plexus of vein should be given, opposite to the second molar. Boundaries: superiorly infratemporal surface of greater wing of sphenoid, inferiorly lateral pterygoid muscle, laterally temporalis tendon, coronae process, medially lateral pterygoid plate, lateral pharyngeal wall, posteriorly condyle lateral pterygoid muscle, anteriorly infratemporal surface of maxilla, posterior surface of zygomatic bone. Content: pterygoid plexus of veins in internal maxillary artery, mandibular nerve and its branches. Clinical feature: extraoral swelling over sigmoid notch area, intraoral swelling in tuberosity area and trismus. Spread of infection: superficial temporal space, deep temporal space, infraorbital space, deep orbital space. Incision and drainage, intraoral approach, no trismus, opposite to second and third molar. Extraoral approach, in severe cases, incision made at upper posterior edge of temporalis muscle. A sinus forceps is directed upward and medially. Palatal abscess. The palatal abscess typically represents the palatally directed drainage of an infected of pulpal or periodontal origin. The palatal abscess is often observed in the premolar molar region and present as compressible mass of swelling, usually lateral to the midline. Boundaries: inferiorly bounded by cortical plate of hard palate, superiorly overlying periosteum, laterally alveolar process of maxilla and teeth. Clinical features: well-defined circumscribed fluctuant swelling confined to one side of palate tooth causing the abscess is tender on percussion. Incision and drainage: incision through the mucosa down to the bone. Care should be taken to avoid cutting of greater palatine nerves and blood vessels. Sinus thrombosis. Cavernous sinus is a cavity at base of the brain which drain deoxygenated blood from back to the heart. Cavernous sinus thrombosis is the formation of a blood clot within cavernous sinus. Spread of infection. Odontogenic route of spread: anterior route to cavernous sinus thrombosis, posterior route to cavernous sinus thrombosis. Anterior route or to the cavernous sinus, when maxillary odontogenic infection route into infraorbital vein in the infraorbital space or the inferior ophthalmic vein via the sinus, they can follow the common ophthalmic vein through the superior orbital fissure and extend directly into the cavernous sinus. Posterior route of infection spread: infratemporal space contain branch of anterior maxillary artery and pterygovenous plexus. Emissary vein from pterygoplexus pass through the foramina in the base of the skull to connect with intracranial dural sinus. Because veins of the face and orbit do not have valves, infection can easily spread superiorly. Signs and symptoms: classic presentation are abrupt onset of unilateral periorbital edema, headache, photophobia, and bulging of the eye. Sixth nerve palsy is the most common. Retinal hemorrhage and decreased visual acuity, fever, tachycardia, and sepsis may present. Treatment: broad spectrum intravenous antibiotics are used until a definite pathogen is found. Nafcillin 1.5 gram IV, cefotaxime 1.5 gram to 2 gram IV, metronidazole 15 milligram, load followed by 7.5 milligram. Surgical drainage with sphenoidotomy is indicated if the primary site of infection is thought to be sphenoidal sinus. And thank you.
My name is Mariam and I'm going to explain complexity of odontogenic infections in the mandible. Submental space infection. It is infected because of infection from anterior mandibular teeth or spread of infection from the lower lip, skin around the cheek, floor of the mouth, tip of the tongue, and sublingual tissues. It contains submental lymph nodes and anterior jugular vein. The clinical features of submental space infection include extraoral findings such as distinct firm swelling in the midline beneath the skin. Skin overlying the swelling is board-like and taut, and fluctuation may be present. Intraoral findings include that the anterior teeth are either non-vital, fractured, or carious. The offended tooth may exhibit tenderness to percussion and may show mobility. The patient may experience considerable discomfort on swallowing. The infection can extend posteriorly to submandibular space or discharge of its contents in the submental region of the face. The incision is transverse and is placed in the skin below the symphysis of the mandible. Submandibular and sublingual spaces are surgically distinct but should be considered as one surgical unit because of their proximity and frequent dual involvement in odontogenic infection. Infected premolar and first molar teeth frequently drain into this space due to their root apices existing superior to the mylohyoid muscle. Extraorally, there is little or no swelling. The lymph nodes may be enlarged and tender. Pain and discomfort on swallowing. Speech may be affected. Intraorally, there is firm and painful swallowing is seen in the floor of the mouth on the affected side. The floor of the mouth is raised. The tongue may be pushed superiorly. Intraorally, an incision is made close to the lingual cortical plate, lateral to the sublingual plica, as the important structures at this site is the sublingual nerve. Extraorally, when both the submental and sublingual spaces contain pus, they can be drained via a skin incision placed in the submental region, pushing a closed sinus forceps through the mylohyoid muscle. The infection can be complicated into sepsis, oral cancer diagnosis, sublingual and submandibular gland infections, and lingual nerve damage during incision. Submandibular space infection. Etiology is infection in lower molars, pericoronitis, fracture of the angle of the mandible, indirect infection, which means spread from other spaces. Clinical features are a painful swelling in the angle of the jaw, and tenderness with generalized constitutional symptoms. Treatment includes an extraoral incision below the lower border of the mandible with a blunt dissection and rubber drain. Also, we will need antibiotic administration and rehydration and complete bed rest. Can be complicated into Ludwig's angina, which is the infection of all the three submandibular, sublingual, and submental spaces, and blocked airway and sepsis. Buccal space infection. This space contains the buccal pad of fat and facial lymph nodes. It is characterized by swelling of the cheek, which extends from the zygomatic arch to the inferior border of the mandible and from the anterior border of the ramus to the corner of the mouth. The skin appears taut and red with or without fluctuation of the abscess, which if neglected may result in spontaneous drainage. Dumbbell-shaped appearance due to lack of swelling over zygomatic arch. Treatment includes an intraoral incision. The intraoral incision is made at the posterior region of the mouth in an anteroposterior direction and carefully to avoid injury of the parotid duct. Submasseteric space is a space between the lateral aspect of the mandible and the medial boundary of the masseter muscle. It contains the masseteric artery and vein, and it is infected because of pericoronitis. Clinical symptoms include severe trismus and posterior mandibular angle edema.
The drainage approach is via an extraoral submandibular approach beneath the angle of the mandible.
Pterygomandibular space abscess. This space lies medial to the mandible and lateral to the medial pterygoid muscle. Anteriorly there is the pterygomandibular vein, posteriorly the parotid gland, and superiorly is the lateral pterygoid muscle. It contains the inferior alveolar artery, vein, and nerve, lingual and mylohyoid nerves, and it is infected because of also mandibular third molar infection or fractured mandibular angle or needle track infection from a mandibular block. Clinical features include little or no facial swelling and trismus, but trismus with no facial swelling is mainly due to needle track infection. Also with pain at the retromolar region, dysphagia, and no obvious swelling extraorally, swelling near anterior tonsillar pillar, and deviation of the uvula. The drainage approach is either extraoral from a submandibular approach or intraoral through an incision placed lateral and parallel to the pterygomandibular race through the buccinator muscle. Parapharyngeal spaces include the lateral pharyngeal space and the retropharyngeal space. Lateral pharyngeal space is a potential space lying lateral to the pharynx. extending from the base of the skull to the hyoid bone. This space is conical in shape, its base being toward the base of the skull and apex toward the hyoid bone. Source of infection from other spaces, which include the pterygomandibular space, submandibular space, from tonsils, and from the lower third molar region. Clinical features include no or minimal external swelling on the lateral aspect of the neck, moderate limitation of mouth opening, rotation of the neck to the contralateral side is painful, dysphagia and uvula is pushed to the opposite side, pharyngeal bulging is seen, which is swelling over the pillars of kyphosis and superior constrictor. The management of this infection includes a combination of intra and extraoral approaches for the management of it. They are preferably done under GA with care taken to secure the airway. The intraoral approach includes a 1.5 cm incision is made on the pterygomandibular raphe, and then sinus forceps is passed through the raphe on the medial surface of the mandible. The extraoral approach is an incision of 2.5 cm is made in the submandibular region, and then blunt dissection is carried through the fascia just anterior to the sternocleidomastoid muscle. Caution must be taken not to perforate the posterior oropharyngeal wall by aggressive finger dissection toward the oropharynx. The source of infection is either from the lateral pharyngeal space, from the lymph nodes that drain into Walder's ring, and rarely from upper respiratory infections. Clinical features include a stiff neck, sore throat, dysphagia, lateral neck swelling and occasional erythema, fever and dyspnea. Mediastinitis is the most feared complication of this space. The most important is to secure the airway. Maybe an elective tracheostomy or fiber optic intubation is considered for airway maintenance. Then there is an intraoral approach, which is generally done for the suprahyoid part of the retropharyngeal infection. This procedure is similar to the one done for the lateral pharyngeal space infection, and the oral incision is made on the mucosa at the medial aspect of the ramus of the mandible. Extraoral approach is better for the infection at the infrahyoid region. Incision is made transcutaneously anterior to the sternocleidomastoid muscle at the level of the angle of the mandible to the level of the hyoid bone.